Hey, hi, folks. Welcome back to Dr. Gilead Show. Today is November 17, 2016. We are on WBGR Radio and Facebook Live. Dr. Gilead Show again. Welcome back. Um, Today, we're going to talk about schizophrenia, which is a big one in mental health. But today, I have a special guest, big special guest. Hey, I have Ken Alford with me. Hey, Ken, tell our folks who you are. Introduce yourself.
Okay, well, thank you. I'm Ken Alford. Again, I'm glad to accept your invitation. I'm the Executive Director of Behavioral Health at Washington Adventist Hospital. I also sit on the Board of Directors at NAMI in D.C. and also on the Executive Chapter for the NAACP D.C. for Behavioral Health. So we try to do some things in the community, but definitely full-time. That's my ministry is mental health.
Good. All right, yeah, you're welcome to the show. Thank you very much for accepting our invitation. This is what we do. And today we're talking on one of the big ones, schizophrenia.
Oh, yeah.
But, hey, folks, like we do, before we start, we like to say that please do not use whatever information you get on this platform to make a diagnosis of yourself or someone you know. And do not take any medication based on what you hear on this platform. It is always good to consult a doctor, a healthcare provider who can help you make the appropriate diagnosis, give you the right medication so that you can do better. Dr. Gilead Show, the producers, and the host and the guests are not responsible for what anyone does based on what they do or say, based on what they get from this platform. So, having said that, I want to welcome you all again to this show. Today we're going to talk about schizophrenia. Schizophrenia is a big one. It's one of the major mental health disorders, a big psychiatric illness, and it's a chronic brain disorder or disturbance that is made up of different symptoms all put together, things like delusions, hallucinations, disorganized speech or behavior. And it's not an uncommon illness. It's very, very common. I was checking at Washington Adventist, how often do you guys see schizophrenia there?
Well, we see it quite a lot. In fact, one of the departments that fall under my watch is the inpatient unit. And probably a little less than half of our patients come in with signs and symptoms of schizophrenia. So we see it in the community, and again, it's concentrated to my unit because it's a behavioral health department.
Yeah, it is big, and statistics shows that 1% of every population, 1% of every population has schizophrenia. In America, we are 310 million people.
Right.
1% of that is huge. So that is about 1% of that is about 30 million people.
That's a lot.
Thereabout. That is a lot of people, and it does not know. It doesn't have any boundaries.
Right.
It occurs in Caucasians, African Americans, Africans, Hispanics, across the board. All ethnicity, all races. If you go, 1% of the population will have that. And it is known that males and females, it occurs in both males and females equally. But the only thing is it occurs earlier
in males.
Right. In males. So in Washington Adventist, you see younger people?
Yes, we do. So we have an affiliation to University of Maryland. The school is like literally right down the street. And okay, sorry. And every time that we see a 18, we take our unit. This 18-year-old, 19-year-old come to the unit. We see them as early as that. We can see them earlier, particularly in our location in Rockville. They can come in as early as 15. They have an adolescent unit. So between 15 and 19, when we see the first symptoms of schizophrenia, we always hope it's something else because of the early onset, but it usually presents that early for men.
Right, and of course statistics say that for men, it presents between age 15 and
Okay.
25 years. While for females, 25 to 35 years.
Correct.
So you have schizophrenia occurring much later in females.
Correct.
And that's why you see females who already have children.
Correct.
And they have a family. While in men, sometimes because it starts quite early,
Correct.
they're not able to develop relationships, get married, and all that.
Correct.
But still, what we're doing, we
Right.
see people get better, and they raise a family. Now,
Can I say one thing?
yes,
about
yes,
that?
go ahead. Yeah.
You know, and this was speaking to this also culturally. You know, they're in terms of how we look at these diseases culturally. Some of our cultures recognize it and treat aggressively, and some don't choose to ignore it. And the problem with ignoring it when it's early, because you know, when I guess we get later into this presentation, how we can treat earlier. The problem is the later you get into the symptoms and the later the age is, it becomes more treatment resistant. So it's important, you know, recognizing it early that it's a real disease. It's not something just a American disease that we make up that just happens here. It happens everywhere. We see all races are affected by it, and recognizing and educating culturally across the board, African American, Indian, Latino, that this happens across all races, and what does it look like, and when do you need to initiate an intervention for treatment?
And you know, some people, I've heard some people say, oh, schizophrenia, there's nothing like that. It's multiple personality disorder or split personality. No, it's a real disease. Yes. But also the thinking is, most people think, oh, someone has schizophrenia, they're dangerous, they're going to kill somebody.
That's not always the case.
That is not always the case.
No.
Yeah, a lot of people, many people who have schizophrenia are not dangerous. They are not hostile. They are not. They're not aggressive.
Right.
Some people will also think that once you have schizophrenia, you're stuck in the hospital.
No, that's not true.
A lot of people with schizophrenia are in their homes.
Working.
Some maybe in group homes. Some in families. Some working, living a regular life. So it is not a. But I know that in the 50s, once you have schizophrenia,
that was the end of life as we know it. Yeah, they use Thorazine, which everybody probably knows is you know, is a gold standard for treatment in the 1950s, and patients were literally just like zombied out, drooling, pretty much sedated and non-functional.
Yeah.
Because we found something that worked, but it just floored the patient. They had no quality of life, you know, in the 1950s.
Yes, because that was the only thing available. And you know, in the 50s, once you have agitation in the unit, they put you in a straight jacket and put some ice or something, some cold water.
Wrap you in sheets.
Yeah, wrap you in sheets. Put some cold water and you freeze up and people calm down. But those things are no more. We have much better treatment. Absolutely. And outcomes are wonderful.
Oh yeah.
You know, I stumbled into something about the people who are born in winter or early spring. Most people who have schizophrenia, if you look back in their history, a lot of them were born in winter or in early spring.
Interesting.
Yes.
Wow.
And they were talking about, why would that be? So is it that when they were pregnant with them, when mom was pregnant with them, now they had an infection, a viral infection, while they were in utero, or they were genetically predisposed to survive some of those illnesses that could occur during winter time. So you have this seasonal pattern of it, but also there is someone was talking about the diet.
Interesting.
So during the time of pregnancy, the diet we take, the diet we eat during those cold seasons, different kind of diet. So maybe those diets affect certain part of the brain, and when the child is born, they come down with schizophrenia. But there are definitely the genetic part of it is clear. It is well documented that there's some genetic component to it.
Yeah, absolutely. We do genograms. You know, even though I'm an executive, I'm also a nurse, and one of the things we do with nursing students is do genograms, and we can actually trace in the family where it came from in terms of the first or second level generation. It usually runs usually a grandparent or uncles may have the gene. We think that is a related factor to getting it, and then predisposition for it. And then we can actually see it clearly running in families and having it run genetically. So we do have some data to support the genetics.
Oh yeah. And even though we say in total in whole population 1%, but it's been shown that in non-twin siblings,
yes,
children of the same parents,
right,
that once one person has schizophrenia,
right,
the other person has 8% chances of having schizophrenia.
Correct.
And also, if a child that one parent has schizophrenia, 12% chance one child will have schizophrenia.
Right.
The other statistic is for dizygotic twins, twins that don't look alike, did not share the same placenta. They have 14% chances of the other. But when you have two parents having schizophrenia, 40% chance.
Definitely.
Yeah.
Yeah, that data is
so,
correct. Yeah.
Yes, and then monozygotic twins that look alike.
I heard it.
Yeah, that one 47%.
Almost half.
If one child that is exactly the same, that share the same placenta, the other one has 47% chance of having schizophrenia. It is so there must be some genetic component.
Correct.
Or they were both exposed to the same virus in utero. So we don't know. There are a lot of things we don't know, but these are all statistics that are out there. But we know the dopamine hypothesis, which is in the brain we have neurotransmitters.
Yes.
Folks, you know what I call chemicals in the brain. So for schizophrenia, we have the dopamine. When dopamine is high, then there's a problem.
Right.
The things like symptoms of schizophrenia will present. And any research in your hospital that they're doing?
So there's a new company. Actually, it's funny that I'm here today because yesterday I invited a vendor. I think I want to say the word is Genome, but there's a vendor now that is actually testing what genetic things people have, what things might lead to disease, and what drugs are affected when they have these diseases. In fact, it's very expensive, of course, because it's all cutting edge, but the technology is getting so precise now that if we diagnose you with this, that we now can kind of tell you which drug would work to support you much, much better than it used to be, where we were kind of just shooting in the dark.
Right. That's the check out the cytochrome P450 in the liver, see what medications will help most. And because we're all, remember, we're not the same.
Right.
Even though we're all human, but our genes are different.
Right.
So the genome testing looks at what medications can really work for one particular person, for a particular disease. So that makes life much easier for us now. Yeah. You can really do that genome testing, and you figure out what medications that could really help the person with minimal side effects. That is a new cutting edge in medical practice, and it's very helpful.
And we're charged now to maintain the patient when they leave. The outcomes. We used to just treat them in hospital or put them in a chronic hospital, but now we're keeping them out in the community. So knowing that drug that would really support them being out in the community as much as they can be really helps guide us in our treatment decisions in terms of that patient being able to be discharged and being maintained in the community.
Yep. Well, folks, we are on Dr. Gilead Show. WBGR Radio, you can call 301-429-9247, 301-429-9247. Hey, Betty, I see you. Thank you for tuning in. Also, Maria? Yeah, Anna Maria, yes. Thank you for tuning in. Dr. Gilead Show, we are talking about schizophrenia, which is one of the major mental illnesses that is ravaging our society. But good thing is we have providers, we have medications that can help. So we were talking about it today to educate people to know more about it so they can get the right and appropriate help that is out there. Now, if you can call in 301-429-9247, WBGR Radio, and if you have a question, we can answer your questions, and also we can, if you have a contribution, you can make from your experience. So let's look at how does schizophrenia really present, because schizophrenia is a combination of symptoms that have been put together. The people you see at the hospital, what are the commonest symptoms that you see?
So the biggest things that we see is something called hallucinations. When we talk about schizophrenia, of course, the brain is basically playing tricks on your senses. So your senses, all your 5 senses, your sense of taste, your sense of smell, your sense of vision, your sense of hearing, your sense of smell, taste, feeling, is all altered.
Yes.
It's not real, because again, he mentioned dopamine. All these chemicals are really displacing the ability for you to perceive the reality around you. So they hallucinate. They hear voices that they respond to sometimes. They hear voices they don't respond to. They see things that don't exist.
Right.
I mean, that's big for us in terms of what we normally see. Person is actively hallucinating and usually is responding to the voices or the stimuli that's causing them disarrangement.
Right. So you know, like, and I see people who come in, they're hearing things, the so-called auditory hallucinations. So people hear things telling them to, oh, go do this. I have a patient who the voices tell him, turn around. He's driving, and the voices say, turn around. He turns around, he gets to the next intersection, the voice says, turn around. And he does that all day.
Wow.
So he's turning around, get to the next intersection, turns around. And he told me, he says, and when I'm tired, I say, how do? You don't eat. When I'm hungry, the voice will say, hey, go to the trash can.
Wow.
And he'll pull over at the trash can, he will dig into the trash can, whatever he gets, he eats, and he continues to turn around all day.
Wow.
But you know, and I saw him I've been seeing him for about 8-9 years. Got him better. He has a job. He's doing well. So the voices could be really tormenting. Sometimes the voices tell them all different kinds of things. What kind of things do they say? The voices.
Well, the voices can be anything from, like you said, the food is bad or the weather is bad to kill someone.
Yeah.
I mean, they can go from the range of that to the one where they're telling you to hurt someone.
Yes.
And depending on the strength of the voice, we call them command hallucinations.
Yes.
They could be a strong command for them to do harm to someone. And again, that's a rare extreme, but again, when they come to us, we do see different ranges of hallucinations.
Yes. Right, and it's amazing the kind of things the voices say. I met a guy a few days ago. The voices told him, "We're gonna kill you." So, and I've been seeing him for about 7 years, and I said, "Okay, these voices have been saying this for 7 years. You know, they're not real." He says, "Man, they're real because they're gonna kill me." Right. And I said, "If they're gonna kill you, they would have killed you." So but it's a torture.
Right.
It's so tormenting on the guy, but he's been dealing with it. He's getting better. Right. So those are auditory hallucinations. There are visual hallucinations.
Yes.
People see stuff, and I've seen people tell me, "Oh, I see like a mouse running behind," or I see people, and all kinds of things that people see. The other ones, the tactile hallucinations, the feeling on the skin.
Right.
I see people talk about bugs crawling on their skin.
That's a common one. Yeah, they say they feel bugs on their skin. They can't get them off, and they're actually reacting to what they see.
They scratch and they peel off their skin, but you say there's really nothing there. No, I see them. I feel them. There's something crawling on my skin. Right. The other hallucinations are like gustatory, funny taste, or olfactory, where you smell things. Right. Someone comes into the office and says, "This place smells of rotten egg," or it smells of something.
Right.
And you said no.
I had one patient that said that they actually smell dead people.
Yeah.
And they kept saying it over and over again. I smell dead people, or I smell blood in my food. Is maybe chicken and something else, and they say I can smell the blood. Can you smell it too?
Wow.
So they want validation that they are smelling.
Right.
You know.
So you can imagine that is something else. The
Right.
other symptom is delusions.
Oh yeah.
Delusions are big
False
and
beliefs.
very difficult to treat.
Yeah, our patients have what we call these false belief systems.
Yes.
They believe that our nurses are, instead of having medications, that they have poison. They believe that the screens around them are FBI agents looking at them, or somebody is spying on them from the screens, or someone is out to get them. Always a persecutory kind of delusion. Never helpful one. It's always one where somebody is really out to hurt them.
Yeah. And I had a patient who every light in his apartment, he used the paper to cover them. The computer monitor, the TV, all
Really?
covered up.
Yes.
Because he thinks that the FBI, CIA are spying on him through those.
Right.
And this unshakable false belief is so hard to get up. You can't tell him anything.
And another one I see, doctor, is religious delusions.
Yes.
They think that they're Jesus Christ.
How many Jesus Christs have
I've
you
seen
seen
a
in
lot
the
of
unit?
them. A lot of them, and they become the religious object for which they worship, and they tell us that, and they hold on. You know, usually they have if they have a Bible, they are actively telling us they are the deity of that religion.
Religion, yeah.
You know, so that's interesting as well.
And a lot of paranoia.
Oh yeah.
I've seen people who they don't want to eat at home,
Right.
or food cooked by their spouse or by their mother,
Right.
because they think someone is poisoning them. I had one recently. He went to the cafeteria, a student, and he thinks that the food is poisoned, so he wouldn't eat, and he almost starved to death.
Wow.
Yeah, until the mother went up to school, and a college student went up to school and brought him home, and he came to me, and it took some time for him to even accept that there was something wrong. So all manners of delusions. The good one, the arithmetic delusion.
Oh, okay.
Yeah.
Okay.
You see people talking about, oh, the president is in love with me.
Right.
Yeah, and
Yeah, and this is kind of similar to what the gentleman that was that I think the one who was tried to assassinate President Reagan, something similar to that. There was some kind of thing going on where he thought there was an affair between another actress and the president, but he actually acted on his delusion and tried to assassinate. So yeah, we do see those too.
Yeah.
The erotomanic delusions.
yeah, it's big. I mean, some people become so paranoid they think their spouse is cheating on them.
See
So
that a
really,
lot.
the spouse is there all the time supporting them. These are all part of the delusions. There are other symptoms like disorganized speech.
Oh yeah.
Is
Yeah, that one is tough for us because when we try to, again, behavioral health staff try to use talk therapy to get people in alignment, but when you have your patient with schizophrenia, unless they're getting something like medication, it's difficult to penetrate through all that fog.
Yeah.
And they're giving you words that you really can't understand. They're throwing words together. They're trying to make sentences that don't make sense. There's no connection to what they're saying that makes us able to understand what's happening to them.
Yeah, the neologisms, they bring
Yes.
new words that don't exist. They
Right.
talk about and they strongly believe that it's a word. They're telling you a story that never happened, and the speech, if you listen to it, it doesn't make sense. And I have somebody talking to me, and he jumps from one thing. I said, I lost you. Come back.
Right.
And he goes back to say it. He says something else completely
Different.
of the child, and so it's so hard. Schizophrenia is a very tough illness, and even the patients themselves, they feel bad. But they believe that something is really wrong. Right. I have a patient who she believes that she had this therapist who also does acupuncture. So, and she says he is with her all the time. I said, well, where is he? He's right here. But that's your husband sitting next to you. No, well, he is here. And there is nothing you will say that will make them make her say, no, it's not. There are some other disorganized behavior.
Oh, yeah.
The
Yeah, well, you got sometimes they will kind of posture
right,
where they kind of go like a goose-like motion, and they can stand there for like a robot.
The catatonia,
Right.
and you see someone and they're like this. They can stay like this
Right.
for hours, for 24.
Right.
And they take different postures. I have seen a guy and he's just like this.
Right. And if you move the arm up and down,
Nope.
you got waxy flexibility.
Yep, it stays there.
It stays just like
No
when
movement.
you moved it.
Yeah,
It's
it's amazing how this illness really affects people. You can imagine at the middle of summer, someone is standing by the street side with a particular posture, catatonia. No movement. It doesn't matter how hot it is. He's sweating. He stays there all day until he decides to leave.
Right.
It's a tough illness.
Yeah, we see that. We see people, they don't speak.
Yes.
You'll say, hello, good morning, how are you? How was your day? What's happening? What can I do to support you? And they will look and say nothing to you all day long.
Stone.
Yeah,
Nothing.
Nothing they'll say. So that's we see a lot too in our unit.
Yeah, and all kinds of bizarre behavior. Sometimes you think, can you imagine, why would someone take her 5 children, drown them one after the other in the bathtub?
Yeah.
So there are just so many things that will touch your heart, and you say, well, something is not right here.
Yeah.
It's mind-boggling why people will do that.
Yeah, it is, and for our staff, we receive annual training, because even though we do this every day, every presentation is different, every patient is different, and you get basically a bag of presentations that range from some of the lighter things we said to some of the more severe. We consider catatonia more severe, because that's when you can't do anything. You can't work, you can't eat, you can't go to school. You're just frozen in your body in terms of your mind is in its own reality, and you're not responsive to the world around you. That's pretty severe.
Yeah, and a lot of the people they have a lot of difficulty sleeping. Someone goes all night without sleep.
Right.
I've seen people. How can someone go 12 days without sleeping?
Yeah.
All he does is wake up, get up, smoke cigarette, stand around, and watch TV. Sometimes stand in front of a TV that is turned off. The TV is not on. He's sitting right in front of it.
Right.
Hours on hours upon hours. And then they get irritable. They argue with family. But a big one is what the so-called anosognosia. They don't believe that they have an illness.
Oh, okay.
So someone who is doing
see that a lot.
someone who has all these symptoms that we're talking about, and you say, hey man, look, you need to go see a doctor. You say, well, nothing is wrong with me.
Right.
You can imagine that is big.
And this is a comment, doctor, if I could comment on that. That is a problem for us in terms of medications, because traditionally we give medications that are by mouth. You give what we call medications you take every day, once a day. But if you don't believe that you have the disease, then you're not going to take the medication.
Exactly.
And if you don't take the medication, guess what? The disease will come back.
Right. And that's why they come to you in the hospital.
Yes.
You get them well. When they get out,
they're back
2
with
weeks,
the same,
3 weeks, 1
back
month.
the way we were.
Yeah, they get very sick. Well, I see Mr. Harrison Pepple. Oh, that's all the way from Nigeria. Wow, thank you for tuning in. Dr. Isoga from Florida. Betty, Anne-Marie, thank you for tuning in. We are on Dr. Gilead's show on WBGR Radio. You can call for any questions, contributions on 301-429-9247, 301-429-9247 on Dr. Gilead's show. And my special guest today is Ken Alford from Washington Adventist Hospital. Schizophrenia, one of the big ones. That's what we're talking about today. Ken, let's take a look at the effect of schizophrenia on people. The individual that is going through this. What is the effect of schizophrenia? And look at it that this is someone, normal child, elementary school, middle school, high school, boom, all hell breaks loose.
So
what is the effect on this particular individual?
So when I teach this, as I sometimes do adjunct faculty work at the university, I always start with my students, imagine a disease that will cost you about 40, in your lifetime, 40 inpatient hospitalizations, that there will be an increase of 12% risk factor for you to commit suicide, because 10 to 12% is the number of all schizophrenics commit suicide because of all this stuff we just mentioned.
The frustration.
And the voices and all those things. Also, you can talk about how the medicines will, if you're poor, don't have resources, whatever race you are, you're going to be homeless.
Yeah.
And if you look around D.C., and when we did that big push to push patients out of the hospital, now we have them on the streets. And they're everywhere now, and even just in the district. You can also expect relationships. There are people who stigmatize schizophrenia. They don't believe that schizophrenia exists, so they cut them off. So they have no relationships that they're connected to. So they're really out on their own trying to survive. And then I guess later on we'll talk about the medications that you're predisposed to. Sometimes some of the meds can even cause you some issues with weight gain and some side effects that we can talk about. And then of course some of the metabolic diseases that predispose you to an early death.
Yeah.
So schizophrenia is it's not just one thing. It's a cumulative effect on your employment status, your relationships, your engagement in society, and then of course the quality of your life. All those things take and in 40 hospitalizations. That's a lot of money.
It takes a lot from the individual. And some who probably have a job, they go into hospital. The next 2 weeks they're back in hospital. No employer wants to keep them.
No.
So they lose their job. They become homeless. They can't afford any good thing. It's very, 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 very frustrating. So the individual goes through a whole lot, and of course the stigmatization.
Oh my goodness.
Yeah, that's a big one.
Yeah, that's big because it scares people because they don't know what they're dealing with. And again, I always speak to this in terms of the cultural domains, because when we do a broad education about schizophrenia, we have to do really more focused cultural education, because we have cultures that don't believe it, that think that if they put them outside the areas that they'll be fine, or they turn their backs on them. And these people really need every family resource they can get their hands on, just to connect to the systems they need to maintain them in society.
And another thing, some people think that, okay, take them to churches, pray for them, and they're going to get healing.
This disease, because of what you mentioned, we know there's a chemical imbalance with dopamine. Unfortunately, the only way to really put that in alignment is you need a medication that can put that back to where what is normal for us in baseline. Right.
And on Tuesday, I saw a patient, a girl who, she says, I believe in spirituality, and but no doctor wants to listen to me. I said, okay, let's take a look at it. How many times have you been admitted into the hospital? She says 15 times. Okay. Now, what do you think is going on? She says, well, I know something is not right, but I believe that I could get healed. Okay. But you're not healed yet. Once you are healed, fine. But if you're not healed, you're being in hospital all the time shows that you're not healed yet. Correct. And we looked through, she quoted some Bible verses, and I said, okay, good. Let's take a look. St. Paul. St. Paul had an illness.
Oh.
Yeah.
Okay.
The Bible says St. Paul had an illness, and he asked God to heal him, and God says, my grace is sufficient for you. So what happened when Paul met Luke? Luke was a physician. Paul took Luke to wherever he went, which means Luke must have been prescribing some medications for him. That's why he took Luke wherever he went. So your belief may help you, but until you are healed, it's advisable to continue to get your treatment, or else you end up in hospital several times, and that completely disrupts the life of the individual.
Right, and we have data too to support how the medications can really help the patient. You know, this isn't a wild science.
Exactly.
When they come in on our unit, and we see them with all the things we mentioned today, and usually we get maybe 70 to 80% of that is abated by medications. Of course, there's other things you need besides medication. Again, the religious piece is a good one, but also family support. But medications play a huge role in making sure that the person with schizophrenia is treated effectively.
Yeah, yeah. Dr. Dr. Soga. Yeah, thank you. A tweet here, Dr. Soga says, thank you for the attention you're paying to this disease. Perhaps it is important to stress to the patient that doctors are doing God's work through our knowledge with therapy and medication balance. So, that's a doctor from Florida. He's saying for our listeners that fine, you're a Christian, you're a Muslim, whatever religion you believe in, it's good to know that doctors are also, the knowledge is given by God, and they're doing God's work through their job. So it's good to have your belief, but also take the medication because it's God's work. Thank you, Dr. Soga, for that contribution. Yeah, that was wonderful. So someone who has schizophrenia has a family, and you can imagine the effect of this on the family.
Yeah, the family is pretty devastated because in their mind, particularly if this person's higher functioning, on a college track, pre-med or engineering or lawyer, and then at 19, 20, 21, they keep having these, what we call these psychotic breaks.
Yeah.
They're like, what is going on? And can he get it together? And when we get that diagnosis, because of the repeated hospitalizations, these families are devastated. It's almost like a death in terms of a loss. They've lost an individual that they feel cannot function the way that they perceive they could function. And then it also changes their level of engagement. Yes. Some families get closer, and unfortunately, we see some disintegrate.
Right, and also, if they're staying intact, you see one family member is almost always kept with this patient. So you're not losing just one, you're losing two people.
Right.
One person is staying to make sure the schizophrenic patient is safe, or not destroying the house or burning down the house or doing things that may hurt him or other people. So you have a situation where one person is sick, another family member is also staying there to take care. At the end of the day, two people are out of the equation. It destroys families, and come on, your spouse is in and out of hospital. How many people will stay?
Yeah, we see a lot of relationships break up.
Yes.
Because of this, particularly when it's a spouse. It's a difficult road, and if the spouse doesn't really understand the disease and what it is and what we can do for it, we do see some strain that sometimes even leads to abandonment.
Exactly, abandonment. But what I do is I bring the family in. I have come to the understanding that once family members, parents or children sit in with me in my office with the patient, and you explain, go through the symptoms, what the patient is doing, why it is happening, they have more understanding, and the family support becomes stronger. Yeah, because a lot of people don't really know about this. They think, oh man, you're acting up. Why are you talking out of your head or something? Man, get it together. Jump out of it. And all that is not possible.
Yeah, that's the work that I do at NAMI. I mentioned I'm on the board of directors of NAMI DC. On my unit, we have this ambassador programs called in our own voice, and we actually have a patient maybe that's been schizophrenic come back and talk to people on my unit about what it was like, what was the journey like, and how they can get back on track. And also it's really to educate families too, because the families are huge for schizophrenics in terms of them doing well, doing their best as they can. And so we educate the families through that in our own voice program with NAMI.
Wow, that's huge. And what is the effect of schizophrenia on the society? Let's say one person has schizophrenia. You can imagine what that will do to the society. I found some huge statistics. Can you imagine? In America, schizophrenia treatment, management alone costs $32 billion a year.
I actually can, that's...
Now, this is nationwide. Now, direct loss, or direct cost is about $17 billion.
Wow.
That means on the individuals, $17 billion cost of treating these people with schizophrenia. Then the indirect cost are the other social services.
Right.
The social effects, because they can't work, so they have to be on some assistance, some housing, and someone will have to take them to the doctors, someone will have to help them do stuff. All that put together, $15 billion a year. That is huge. So on any society it's a huge expense. If you're looking at the cost of healthcare,
Right.
it's a huge part of that cost. So then of course we're not talking about the loss of job time, the work time. This person is not productive anymore. Yeah, go ahead.
I was going to say, yeah, we you know, when we get schizophrenics on my unit, they're not people that are usually out within 3 or 5 days.
Exactly.
They usually take a long
2
time,
weeks.
longer to really get and target the symptoms. And that's if they're not resistant on medications. That's if it's just a straight run of the medication and they can do well. But you got some, I guess you'll mention, that are resistant, and that's a different level of treatment we need to focus on.
All right, you're tuned to Dr. Gilead's show. We're going to take a short break. Stay tuned, don't go away. We'll be back in a minute, and we are on WBGR Radio and Facebook Live. Stay tuned. We'll be back in a minute.
Nice. Yeah, man, they put my mother on Haldol.
Yes.
And we went through that like since I was in 9th grade. Then this doctor came to us, says chemical imbalance. So this natural doctor said, well, the chemical imbalance ain't Haldol,
Right.
So she actually had an episode of 20 years. Yeah.
So she actually took her off the Haldol?
We took her off everything, put her on natural stuff, and she had it.
She's okay?
Yeah, things happen. So maybe from the beginning, she may not have had schizophrenia.
Yeah.
Well, that's
because you can have a psychotic break.
Oh, yeah.
That's
but
not
she said
even...
saying all the stuff y'all was saying, like all this stuff buzz on her.
Right.
Man, we didn't know what was going on. She was hospitalized a lot of times, man.
Wow.
Yeah.
None of that stuff never worked.
We have patients that come in, they're doing K2 spices, and they're psychotic, and it looks like schizophrenia on the surface because they got all the stuff that we mentioned, but then after they stay long in the system, it burns out of their system, then we realize it was a drug-induced psychosis, which is different from, which actually, I won't say better, but we like that better because we know that's self-limiting. Once they're out the system, they clear back up. This is a pure genetic anomaly, and it will not go away. It will stay with you until death do you part.
It is. It's a tough illness. Yep.
And there's different variations of it. You can get the paranoid type. You mentioned the undifferentiated type. The catatonic type.
There's a movie that Diana Ross played in. I can't think of the name.
Oh, I remember that one. She was going to medical school, and she got Brandy. I think Brandy was her daughter.
Yeah. Oh, that was.
Remember that.
All right.
That's good, man.
You help out there. You have any food?
Yeah, this stuff is interesting, man. This kind of stuff people need to hear. Daily basis,
Yeah.
And even with the drugs now too, we have I'm on the whole mission. We use long-acting injectables.
Right.
Because we take the power of the pill out of the hand. We give them we use Invega and Abilify Maintainer. Of course, the decanoates are always good, but we give those
have more problems.
Cleaner drugs. But we try to keep the pill power.
Yeah.
We get the power.
It's not easy to take pills. Anyway. Yeah.
And we don't have things. I don't take pills. I wouldn't take a pill every day.
Every day. It's hard. That's tough.
And that's huge for them.
Yeah. So, hope that a lot of people will get the message and really come out and
I shared this camera on your phone. I shared this camera on your page.
Okay.
Yeah, I just figured out how to do that.
Oh, it's on his page?
Yeah.
Okay.
Yeah, a little better angles.
410-721-7155 to plan your Skate Zone event. It'll be an experience your organization won't forget. We do all the work, you have all the fun.
All right, folks, welcome back to Dr. Gilead Show on Facebook Live and on WBGR Radio. Dr. Gilead Show, I have my special guest today, Ken Halford. So we are talking about schizophrenia. You can call on 301-429-9247, 301-429-9247. If you have any questions, you can ask, and any contributions will be welcome. Hey, I see Ms. Beverly. Thank you for joining. Thank you, Dr. Soga. Thank you, Mr. Pepple. We are on WBGR Radio, Facebook Live on Dr. Gilead Show. Welcome back. Talking about schizophrenia. Let's take a look at the treatments. What are the treatment options out there? The main treatment out there is antipsychotics, medications. And coming back from the old days, 1950s, when we used to use Thorazine and all that, we moved up to things like haloperidol and fluphenazine. These are all the what we call typical antipsychotics. But there are newer antipsychotics, and things like risperidol, Abilify, Invega. Yeah, different types. And the biggest and best of them all is clozaril, which is good. But what are the challenges you have in the inpatient unit with patients coming in with regards to medications?
Well, I say we have a registered nurse that gives these patients their medications on the inpatient unit. Well, when they leave from us, there's not a registered nurse waking them up and helping them in the evening. So naturally, when they feel better, a lot of our patients don't take their medicines anymore, or it sometimes even financial, in terms of them being able to afford the medicine. So whatever that factor is, and they stop medication compliance, they go back into this downward spiral.
Yeah.
And every time they have a episode of schizophrenia break, it costs them brain power, their cognitive function. They go to a different baseline every time. So it hurts the brain, it hurts them, it hurts their functioning every time they have a psychotic break because I'm not taking meds.
Right. And saying that, looking back into history, Kraepelin, one of the old psychiatrists, called schizophrenia dementia precox.
Oh, yes.
Dementia precox. That means early dementia. And because he saw people in their 20s, early 30s having dementia, poor cognitive function, because there was no medication to treat them.
Correct.
So, but those things don't happen anymore because we have good medications that we use to treat people. And because, like Ken said, if you're not treated, every time you decompensate and back in hospital, it affects your brain. So you continue to, and I have a lot of patients who say, I can't remember anything.
Right.
I can't remember, and it's a struggle.
Right.
So the medications are out there, but these medications have side effects.
Yes.
There's one big side effect that is called tardive dyskinesia, and that is involuntary movements. So you see people, they're shaking like Parkinsonian symptoms.
Right.
Their lips twitch, they could blink, and they have these uncontrollable movements, muscle movements. That is very common with the old antipsychotics. But the newer ones, like you were saying, the metabolic syndrome.
Right. Yeah, we see particularly akathisia, that's restlessness.
Yeah, motor restlessness.
Yeah, they got ants in their pants and they need to dance. They can't sit still. We see somnolence where they get sleepy a lot.
Yes.
They can't stay awake in group because of the medication, kind of makes them sluggish. Again, the newer ones like Zyprexa, Risperdal, Seroquel don't have the nasty side effects, but somnolence and restlessness is something that they usually have to deal with, and sometimes even weight gain.
Weight gain is big. The so-called metabolic syndrome. You see someone, they start on these medications, Zyprexa or Invega, and they gain weight.
Right.
And they eat so much. So what we do to guard against that, the protocol is, before you start anyone on those medications, you check their weight, check blood pressure, use a tape to measure their waistline around the umbilical region and record these. You recheck the weight after a month, and most of them who will gain weight, you will see a major weight gain in 1 month to 3 months. And if that is happening rapidly, you need to change that medication. Then we also check the cholesterol level, blood sugar, because it's been shown that these medications can cause increase in blood sugar and increase in cholesterol. We don't want anyone getting heart attack, so you check those things. If the cholesterol is increasing, the blood sugar is increasing, they're becoming diabetic, then that has to be managed. But I had a patient who the cholesterol went up, and I said, we need to change this medication. He said, no. Let's find a way to treat the cholesterol. This is the best medication that has worked for me. He refused to have us change the medication. So what we did, we put him on 3 cholesterol medications. And the cholesterol is well controlled. He's doing well. He's working now. And he's happy. He has his car. He got his driver's license back. He's doing very well.
That's good. All right.
So, and education. Educate the patients about the medications. What I know we also use therapy, psychotherapy.
Yeah.
Anything else you want to talk about the medications?
Well, I want to say one more thing about the meds. Now, we talked about the patient taking the medications by mouth every day, but now we have something called long-acting injectables, where we give them one shot by a registered nurse. The doctor prescribes it, and then it keeps them symptom-free for about 30 days.
Right.
There's a lot of medications out there that do that now, and we have a lot of choices. And we use those pretty much so where I work to make sure that the patient now can stay out and don't worry about taking a pill every day.
There's one you give once every 3 months now.
Yes, that's
so. I have a patient every 3 months, but I still like to see him once a month to make sure he's doing okay. But he comes in, I give him the injection once every 3 months. He's doing well. He's back to school.
Wow.
Doing so good. So there are good medications out there. The big one thing, there are patients who really you need to get a thing like ECT, the electroconvulsive therapy. We're going to talk about that one day on this platform as well. So there are some. Then there are medications like clozapine, which is very good. Among all the medications, it's still the best, but it has a bad side effect. Yeah, it can wipe out your white blood cells. So we have to do blood draw every week for the first 6 months. To make sure that the white blood cells are good. If they're good, we move to blood draws every 2 weeks. And if it's good, within 1 year, you do it once a month. And people have gone back to college, graduated, raised a family on clozapine. A very good medication, but it has to be closely monitored. The other type of treatment is therapy, psychotherapy. In the units, what do they do?
So we do cognitive behavioral therapy. So we talk about, and that's a big word, right? CBT. But basically what it is that we have the issue that we're addressing, and then we use reality-based orientation. We tell you this is the issue, and what are the things that we need to do to fix the issue. Could it be, particularly if you have a issue with work and a disconnect between your boss and working because of your illness? How do we give you coping skills that when you hear your voices, you see things? Are you using your medications? Are you calling your therapist? Are you letting your psychiatrist know? We're giving you some very distinct things that you can do to fix the issue. And CBT is very effective once the patient is medicated. And I want to say that very clearly. The patient must be medicated before you can do any of this stuff.
Because without medication, they can't comprehend what you're talking about. So medication is the key, especially for this particular illness. Once you get them stable, every other thing will fall in place. It's very, very important that they get on medication, first of all. Then, but also one thing, a lot of people who have schizophrenia smoke cigarette a lot.
Yeah, we do see a high propensity for nicotine addiction in people who are also schizophrenic.
But also it's been shown that nicotine increases the rate the body metabolizes the antipsychotics.
Oh, really?
So that's why they come into your unit, you give them, say, 4 milligrams of a medication, they're well. They don't smoke. When they get out in the community, they smoke a pack of cigarettes a day. Within 2 weeks, they end back in hospital. because the nicotine
Oh.
increases the rate. Their body metabolizes the medication. The body wipes out the
Wipes it
medication
out fast.
fast. So what worked while they were in hospital is not working anymore.
That's
So,
interesting. That's
yeah.
why we need those wellness checks.
Yes, yes. I do a lot of education groups on because I also work in an ACT program.
Okay.
Yeah, which is assertive community treatment program where since after the deinstitutionalization, the chronically mentally ill came out of the hospital. So we go to see them where they are. So we have groups and we do psychopharm education, tell them about the medications, how our life events, how the things, the type of life we do affect the medications and affect the illness. So we talk about these things. Then, of course, people are, because of the circumstances, people take advantage, give them cocaine to use, heroin, all these will make the illness worse. Especially someone who is doing well and then he uses cocaine. Cocaine will push up the dopamine.
Right. Exactly.
They become sick again. So these are all the different ways they can get help. But other types of therapy, group therapy, is something that helps a lot.
Yeah, that's huge because sometimes people get strength when sharing their story with other people. who
Bingo,
have similar,
yes.
Like someone like me, for instance, they may not make that serious connection, but they'll connect to someone who went through the illness program and understanding what it is, and they can connect and they can say, hey, this is what I did when this happened. So group therapy is effective for them to be able to communicate and also learn coping strategies. What to do when you have anxiety because of schizophrenia, what to do when you feel depressed because of schizophrenia, what things you can do to activate when you're feeling that this disease is taking control. Group therapy helps push you back into a state of alliance with yourself and the universe.
Right. And especially in groups, people will talk of how they got better, what worked for them. Then, you say, okay, well, and they tell you their story. If this guy who was that ill could get better, then I can do it. How did you do it?
Exactly.
You learn from it, and people do real good. Of course, family therapy is another big one. People come together, you bring the family together, and talk about the illness. They know more about what the family member has, how to support. Is
Huge.
It's huge, yeah.
I see, and from my eye, from both as an administrator and also as a nurse, that people with schizophrenia have better outcomes, really good outcomes, when there's 100% family involved.
Yes, yeah, you're right.
You know, family is huge in their treatment because it's going to help to create the safety net if they have an acute episode again. It's going to create education for them and the family, and it's going to provide the patient with a support that they can reach out to and talk to and give them hope when they think that there's nothing can be done. So family support is huge with patients with schizophrenics.
Right, and maybe what we're here saying that family members should be a little patient.
Oh, yeah.
Be a little patient with your family member who has schizophrenia. They are not just doing what they're doing because they want to do it. Be patient, help them get some help. You'll be surprised. There'll be a huge turnaround, and you'll be a happy family one more time or once again. So it's really because they need your support. They need your support. We ran out of time. What are the resources available out there for people with schizophrenia? I know you talked about NAMI and all that.
Oh my goodness, NAMI. We have NAMI DC, NAMI Montgomery County. You can call the national number, the 1-800 number. You can call the local number. They give you education about what it is.
Yeah.
They can teach your family members on how they can get in alignment. NAMI is big about educating the families about how to deal with, and as I mentioned, family is huge for the survival and the prognosis of schizophrenia. So that's what NAMI is for, and it's a local chapter right here in Montgomery County as well. Right.
Yeah, we had the NAMI, the ex-president of NAMI in PG County. He was here with us. I think some episodes ago.
Oh, okay.
Yeah. So NAMI is out there, but also there are individual providers out there. You just go online or ask your insurance company. Your insurance healthcare provider, insurance, ask them who are the doctors that are credentialed and therapists, support staff, the resources are out there. Just call your insurance company, and if not, just go online, Google people, and you will see. You'll be amazed what is out there. Go ahead, Ken.
In a hospital too, you know, when you have a person that's really having an episode where you don't understand, they're threatening maybe some things to hurt themselves or others, please call your hospital as well, because they have resources. Emergency rooms do acute management, which they help the person if they're really in an acute phase to help bring them back to a place where they can get all the wonderful therapies that we mentioned earlier.
Yeah. So there's a tweet asking what is the frequency of follow-up at the doctors for a patient with schizophrenia. So for me, when I see them the very first time, depending on how ill they are, I make sure I see them a week later and adjust medications. As they're doing better, I can extend it to every 2 weeks. But once they are stable, it's always good to see them at least once a month. Once a month. But I have people who are doing so well, I see them once every 3 months. It depends on how well they're doing, but also how knowledgeable they are about their illness. If they have a good family support, they have a spouse who can call me and say, hey, I think my spouse is getting sick again. And I also educate the patient. Once you start having problems sleeping, call me. That is a telltale sign that something is not right. So educating the patient, educating the family will help them know when something is about to go wrong. But otherwise, once a month is a good time to continue to take care of that patient. But if they are doing very well, they're working, they're living a normal, healthy life, once every 3 months is not too long. But for every patient I see, the maximum I go is every 3 months. At least I keep an eye, make sure that they're doing well. And a lot of people do well, especially with good medications.
Yes.
At this present time. I see, hey, Victor, thank you for tuning in. Ken, anything else, any final word you want to tell our viewers and our listeners?
Yeah, I just want to say, you know, even though when you hear the word schizophrenia, sometimes it induces fear and, you know, whatever thoughts that may come, this is something that we can treat. Our treatments are getting cleaner.
Yes.
And there are a lot of things, a lot of resources out there that will help and support the patient and family. So please, activate that. And then that's the way you can treat your loved one and have a life, quality of life. Even with schizophrenia, you can have a decent, good quality of life with schizophrenia.
Exactly. And people are doing well and making progress, gone to college, graduated, raised a family, a job, and a lot of people with schizophrenia are working. So it's a treatable illness. Go get the help you need, and you'll feel much better. We've come to the end of today's episode of Dr. Gilead Show. Yes, time moves so fast. So thank you for tuning in. Thank you for listening. Dr. Gilead Show on WBGR Radio. My special guest, Ken Alford. Thank you for coming. We appreciate having you. We're gonna do this more together because I think people need a lot of help here.
Absolutely.
Yeah, we need to pass the information. So thank you, folks. Thank you for tuning in. I will see you again next week, Thursday at 1 p.m. Thank you very much.
Drew.